Hello everyone, I am Dr.Somya Govil from the Department of Periodontics and Preventive Dentistry, Babu Banarsidas, College of Dental Sciences, Lucknow. Today I will be taking a lecture on pulp capping. We will be dealing with both indirect and direct pulp capping today. What is indirect pulp capping? A procedure wherein a small amount of carious dentine is retained in the deep areas of the cavity to avoid exposure of the pulp, followed by placement of a suitable medicament and restorative material that seals off the carious dentine and encourages the recovery of the pulp. As we all know, any procedure has its own indications and contraindications. The indication of indirect pulp capping are as follows. First, you need to take the history. There has to be mild discomfort from chemical and thermal stimuli. And there has to be an absence of spontaneous pain. In the clinical examination, what do we see? We see a large carious lesion, absence of lymphadenopathy, there is normal appearance of the adjacent gingiva, and the tooth color is also normal. On the radiographic examination, we see a large carious lesion in close proximity to the pulp. There is normal lamina dura, there is normal periodontal ligament space, there is no interradicular or periapical radiolucency seen. Now we will talk about the contraindications. The patient will give a history of sharp, penetrating pain that persists after withdrawing the stimulus. Prolonged spontaneous pain, which can be present during the night time. On the clinical examination, we can see there is excessive tooth mobility. There is parallus in the gingiva approximating the roots of the tooth. There can be tooth discoloration present and non-responsiveness to pulp testing techniques. On the radiographic examination, we see a large carious lesion with apparent pulp exposure, interrupted or broken lamina dura. There is widening of periodontal ligament space, and there is radiolucency at the root apices of furcation areas. When we see all such things, we do not go for the procedure of indirect pulp capping. What are the traditional materials which we use for indirect pulp capping? There are two of them. One is the calcium hydroxide and second is the zinc oxide eugenol. Calcium hydroxide, its mode of action is to serve as a protective barrier for pulp tissues, blocking patent dentine tubules and neutralizing the attack of inorganic acids and their leached products from certain cements and the filling materials. There are a few advantages of calcium hydroxide. It is initially bactericidal and then it becomes bacteriostatic. It promotes healing and repair. It gives a calcium bridge formation. It helps in the formation of reparative dentine, and it also stimulates odontoblastic activity. Things do come with disadvantages too. Similarly here, what are the disadvantages of calcium hydroxide? It does not exclusively stimulate dentinogenesis. Coagulation necrosis takes place. There is lack of adhesion to hard tissue, inability to provide adequate seal against microleakage, and it dissolves under restorations. Now we come on to the zinc oxide eugenol. Its mode of action is demonstrated by the sedative effect it has on the exposed dentine. Zinc oxide eugenol cements are supposed to be the least irritating of all the dental cements and are known to have an anodyne. What is anodyne? Anodyne is a soothing effect on the pulp in deep cavities, and this helps to reduce the pain. What are the advantages of zinc oxide eugenol? It is bacteriostatic, it has good sealing properties, it has very mild pulpal responses, it has an obtundant effect, and it's least irritating to any tissue. Disadvantages of zinc oxide eugenol: it produces chronic inflammation, it lacks formation of calcific barrier, it does not chemically adhere to the tooth structure, and it has the highest solubility in oral fluids. What are the treatment procedures? How you perform this procedure of indirect pulp capping? There are two types of techniques. One is a one appointment technique, and the second is a two appointment technique, where you have to give 2 sittings to the patient. The treatment in the first appointment: you need to give the local anesthesia and isolate the tooth with the help of a rubber dam. Establish an outline form with a high-speed burr. Remove the superficial debris and majority of the soft necrotic dentine with slow speed handpiece using large round burr. Care must be taken to avoid the pulp exposure. All caries except lying over the pulp has to be removed. Stop the excavation as soon as a firm resistance of sound of dentine is felt. Peripheral carious dentine is removed with a sharp spoon excavator. The cavity is flushed with saline and dried with cotton pellet. The site is covered with calcium hydroxide and is filled with zinc oxide eugenol. If there is the remaining tooth structure which is insufficient to retain the temporary filling, a stainless steel band or a temporary crown must be adapted to the tooth to maintain that filling. This is how we can appreciate the carious lesion in a tooth and how we give a base, or we just cap the pulp stump with the help of calcium hydroxide, and then the remaining restoration, that is the temporary restoration of zinc oxide eugenol, is done. Now in the second appointment, the patient comes over after about 6 to 8 weeks. Between the appointment, the history must be taken first so that we can rule out any sign or symptom of pain or any pathology present. We need to take a radiograph and see that there is no pathological lesion that has been formed. The treated tooth is re-entered after 6 to 8 weeks. Again, you take a bite wing radiograph and observe for the sclerotic dentine. Then carefully remove all the temporary filling material. On re-entering, caries will appear arrested, flaky, and dried out. The color will change from deep rose red to light gray and to light brown. The texture will change from spongy and wet to hard. The cavity preparation is washed out and dried gently. Then you cover the entire floor with calcium hydroxide. The base is given and the final restoration is placed. This is one of the cases we did in the department after IPC and then post-operative, that is 6 to 8 weeks after IPC. We can very well appreciate that there are no changes in the periapical area in both the radiographs. Next, I will be talking about direct pulp capping. It is the placement of a medicament or a non-medicated material on a pulp that has been exposed in course of excavating the last portions of a deep dentinal caries or as a result of trauma. What are the indications? There is a pinpoint mechanical exposure of less than 1 mm. Exposed pulp tissue should be bright red in color. Hemorrhage should easily be controlled with the help of dried cotton pellets with minimal amount of pressure. The exposed area should have a dry, clean, uncontaminated field. Exposure duration should be within less than 24 hours. The tooth should be asymptomatic, showing no signs of pulpitis. The contraindications: spontaneous or nocturnal toothaches, excessive tooth mobility, thickening of the periodontal ligament, the radiographic evidence of focal or periradicular degeneration, uncontrollable hemorrhage at the time of exposure, or any purulent or serous exudate from the exposure. There are a few limitations of direct pulp capping in the primary teeth. According to the AAPD guidelines, what does direct pulp capping procedure does in primary tooth? It causes internal resorption. There is high cellular content in the primary teeth. There is abundant blood supply. So there is a faster inflammatory response. And there is poor localization of infection. That is why necrosis and interradicular involvement does occur when we are going in or we are trying in for direct pulp capping in primary teeth. Materials used are calcium hydroxide and zinc oxide eugenol. Calcium hydroxide, its mode of action is by coagulation necrosis at the contact surface of the pulp. When viewed histologically, the underlying tissue differentiates into odontoblasts. This results in the formation of a reparative dentine bridge. What are the advantages of calcium hydroxide? It is antibacterial in action. Rapid tubular dentine formation takes place. Formation of calcific barrier is there. Has osteogenic potential. Stimulates odontoblastic activity. What are the disadvantages of calcium hydroxide? Produces coagulation necrosis, has irritating effects, causes internal resorption in primary teeth, and lacks adhesion to hard tissue. Coming on to zinc oxide eugenol. Its mode of action is by the sedative effects on the exposed dentine. They are the least irritating of all the dental cements. And they are also supposed to have an anodyne or an obtundant effect on pulp in deep cavities, thus reducing pain. What are the advantages of zinc oxide eugenol? It has bacteriostatic property, its minimal pulpal responses, sedative effect, and least irritating. What are the disadvantages of zinc oxide eugenol? It produces chronic inflammation, it lacks the formation of calcific barrier, it does not adhere to the tooth structure, and it has the highest solubility in oral fluids. What is the treatment procedure? When an exposure occurs, the area should be appropriately irrigated with non-irritating solutions like normal saline, just to keep the pulp moist. Care should be taken not to push the necrotic and the infected dentine chips into the exposed pulp during the last stages of caries removal. Hemorrhage at the exposure site should be controlled easily with the help of cotton pellets. The exposure site is dried and the medicament is placed directly in contact with the pulp tissue to exert a pressure and the reparative dentine bridge response. The tooth is first restored with an interim restoration, and observation period is again 6 to 8 weeks here. If there are no symptoms present, then the tooth is finally restored with a permanent restoration. Here again, we can appreciate this case. As you can all see, the exposure, the carious exposure is very, very near to the pulp. In the second picture, we all can appreciate that the medicament has been placed, and over there, there is an interim restoration which has been placed. The last radiograph does show that a perfect bridge has been placed, made, and then there is no periapical radiolucency present too. The tooth is healthy and asymptomatic. Now we would like to talk about the recent materials. These are the list of the recent materials which are available for both direct and indirect pulp capping procedures. First is the MTA, then we have the corticosteroids and antibiotics, we have the interned materials, the collagen fiber, the denatured albumin, laser, bone morphogenic proteins. Mineral trioxide aggregate. It is being used as a pulp capping material in mechanically exposed pulps and for root end induction in immature roots. Mineral trioxide aggregate is prepared as a mixture of powder and water and is used in the slurry form, which gradually hardens in the oral environment. What are the indications of mineral trioxide aggregate? Carious exposures in teeth with incompletely formed roots, as a pulp capping agent and as a root canal filling material. Here we are using it as a pulp capping agent. What are the contraindications of mineral trioxide aggregate? The primary carious pulp exposures, permanent teeth with history of spontaneous pain, radiographic evidence of pulpal or periapical pathosis, calcification of the pulp chamber or the root canals, excessive hemorrhage at the site of the exposure, and exposures with purulent or serous exudates. What are the advantages of mineral trioxide aggregate? It prevents microleakage, it is biocompatible, it promotes regeneration of the original tissues when placed in contact with dental pulp or periapical tissue, has the ability to seal the dental pulp from bacterial and chemical invasion. It prevents toxicity, it prevents tissue irritability, and it helps in the dentinal bridge formation. What are the disadvantages of mineral trioxide aggregate? It causes mild periapical inflammation. There are areas of solitary calcification communicating with the deposited secondary dentine. Pulp tissue reveals inflammatory cells and a few areas of necrosis, and the setting time of this material is about 3 to 4 hours. Coming on to the corticosteroids and the antibiotics, it was introduced by Brosh J.W. in 1966. They are effective against traumatized tooth and have an obtundant effect on the acute inflamed pulp. They are antimicrobial in nature. We will now talk about the inert materials. These inert materials have the property of bacterostatic and hemostasis. They produce less inflammation but does not provide a continuous barrier of reparative dentine on the exposed pulp. Then we will talk about the collagen fibers. The collagen fibers influence mineralization and are less irritating than calcium hydroxide. This is their one very major advantage. It forms a dentine bridge in about 8 weeks of time. Denatured albumin. This protein has calcium binding properties. When applied on the exposed pulp, the protein may become a matrix for calcification, thereby increasing the chances of biological obliteration. Laser. The acronym for laser is light amplification by stimulated emission of radiation. Meyerman introduced laser for the first time. In the pulp capping, the laser was introduced by Meritz in 1998. Good results were seen with the use of laser, and the laser we use here is Nd:YAG laser. Bone morphogenic protein. It is also called as osteogenic protein 1. Urist had discovered them in 1967. It is a bioactive capping agent. Finally, we settle down with biodentine. It is a calcium silicate based material. Its advantages include fully biocompatibility, acts as a dentine replacement, excellent sealing properties, adequate strength, and creates fast setting bridge. A dentine bridge is formed very quickly with it. It needs wet field for the setting. Here is where I end my lecture today. Thank you for your patient hearing. Thank you so much.